All right. Good afternoon, everyone. Sorry that we have to start a few minutes late. I think this was because of the technical hiccups here at the hub. Nonetheless, we are now connected and we are ready to begin. So I would like to welcome you to session number 13, case number 12 in 2019. And today's topic will be discussing treatment failure. That is the identification and management. And to help us discuss this topic is Dr. Lottie Achambwa, who is part of University of Maryland. And as the discussant who will be joining us will be Dr. Chanda and a few people in the hub here. To facilitate this session, I'm Dr. Francis Mpeta. And within the hub, we have got a number of physicians. Among them, Dr. Folo Shisombo is an ID physician. We have got registrars from AIDC. We've got doctors and from PCOE and AIDC as well. We've got elective students from University of Maryland and also registrars who are rotating with us from psychiatry. We've got a number of hospitals who have joined, who are too numerous to mention at this moment, and some individuals. So we welcome you and we encourage you to participate fully in these deliberations. So we will start with a didactic and then the case presentation. But before we do that, I would like to ask Dr. Foloshi to give us a recap of what we discussed last week, that is on PrEP.
Thank you, Dr. Mpeta. Apologies once again for the slight hitch that we had. I will not take much of your time. Last week we discussed PrEP, the importance of viral load monitoring in the HIV positive partner, the importance of 3-monthly tests in the HIV negative partner. We also discussed that PrEP does not prevent STIs. It also doesn't protect against pregnancy. In order to discontinue PrEP, one must be undetectable. So at least 2 viral loads, 6 months apart, less than 200. For you to be U is equal to U, which is undetectable is equal to untransmissible. Thank you.
Thank you very much, Dr. Foloshi, for that recap. And without much ado, I think we'll go straight into the didactic presentation by Dr. Chambwa, which is on treatment failure, the identification and management of treatment failure.
Good afternoon, everyone. My topic today is on treatment failure, as has been mentioned. Talk about how to identify treatment failure and how to manage patients who have treatment failure. We'll probably spend quite a bit of time on discussion. What I'll discuss is mainly based on the guidelines, and then later from the cases and the poll questions, we can address situations that may arise that may not be addressed directly in the guidelines. Next slide. So my goals in this presentation are to ensure that everyone is able to recognize treatment failure and outline the possible causes of treatment failure, and after identifying them, what the next steps would be. We'll talk more about second-line treatment. We'll touch a bit on third-line treatment as we discuss the cases. And this is the same outline that talks about the objectives that I mentioned earlier. Okay, we'll start by reviewing global data on where we are in the 390s. This is from UNAIDS. So globally, 70% of individuals who have HIV infection know their status. And then of those, 27% linked to treatment or on treatment, and 82% of those that are on treatment virally suppressed. So none of these have reached the goal of 90-90-90. And this is data from 2016 from Zambia, which shows the proportion of individuals who have HIV infection who are virally suppressed throughout the country by province. So some provinces like Western Province have very low rates of viral suppression, about 50%. So of all the individuals that have HIV infection, only half of them are virally suppressed. So Western Province and Northern Province are some of the lowest. Then you have provinces like Eastern Province with about 67% of individuals who have HIV infection who are virally suppressed, and then Southern Province has 63%, and then the rest of the provinces kind of somewhere in between. And then this slide is on individuals who are on ART. Again, rates of viral suppression. The third bar is referring to the viral suppression among males and females, and then the total. And as you can see that close to 90% of those who are on ART are virally suppressed, about 89.7% in females and 88.2% in females. But from the first 90, you can tell that not many people know their status. So once people are on treatment, they tend to get suppressed. Not many people have been identified yet. So we still have a huge gap of individuals that need to be identified, that need to be put on treatment so they can get suppressed. There's still some work that needs to be done to get virus suppressed, but then we also need individuals to be identified. So here's the first question. Treatment failure is defined as viral load of more than 1,000 copies per ml after at least 1 year on ART. True or false?
So the poll has been launched.
Slide down so they can see the whole question.
I think we seem to be having a rather slow connection there. Okay, so we can now vote. The poll is up. So treatment failure is defined as viral load of more than 1,000 copies per ml after at least 1 year on ART. True or false? Only about half of us have voted. A few more seconds. Okay. So Dr. Chamba, can you just comment?
Okay, we can go to the next slide.
Next slide.
Okay, so according to WHO and the Zambian guidelines, viral load is defined as having a viral load that's more than 1,000 copies per ml after somebody has been on treatment for at least 6 months of a new regimen. So this could be the start of ART in treatment-naive patients or patients who have failed the treatment regimen and you change to a new one. After they've been on treatment for at least 6 months, the viral load is done, and it's above 1,000. That's treatment failure. The additional definition is that this should be at least 2 viral loads that are done within a 3-month period, with supportive adherence done in between the 2 measurements. As you can imagine, somebody may not have been taking their drugs at the time the viral load was done. So the purpose of the adherence counseling is to ensure that all the issues that may have contributed to a high viral load are addressed. I'll just mention a couple of additional terms that are mentioned in the WHO guidelines and some in the Department of Health and Human Services from the United States of America. We follow the WHO guidelines, but I thought 1 or 2 things from there might be helpful for us. So So you might have heard of a term, virologic blip. This is when an individual is suppressed, they're virally suppressed, and then after a while, they have a detectable viral load. And then there's a return to virologic suppression. So that is called a blip. And then there's also WHO kind of gives a broad definition and defines this blip as viral load ranges of 50 to 1,000 copies per ml. So anything that's detectable up to viral load copies per ml. The next polling question.
So the next polling question is, HIV-associated dementia can contribute to treatment failure, true or false? So we shall launch the second poll. You can vote there. HIV-associated dementia can contribute to treatment failure. Seconds. Okay. Next slide.
So when we get a patient with a viral load that's high, what are some of the likely causes of a high viral load? And these can generally be divided into patient-related factors, HIV-related factors that's related to HIV virus itself, and treatment regimen-related factors. Talking about patient-related factors, and I noticed that a number of, over 100% mentioned that HIV dementia can contribute to treatment failure. There could be comorbid conditions. These are diseases or conditions that an individual has that contribute towards treatment failure. These include conditions like mental health disorders. If someone has depression, they've lost hope of ever getting better, or they've lost hope in life, they're unlikely to take their treatment. If someone has dementia or HIV-associated neurocognitive disorder, they may mean well, but ultimately forget to take their drugs. So that's how HIV-related conditions can. Okay. I think I was on mute, so you may have missed some things. So HIV-related factors.
Clinical appointments.
Okay, so clinic appointments, it could be work-related travel or other family engagements. Adverse drug events, including diarrhea from PIs, high purulence for patients who are heavily treatment experienced. That could be a factor in contributing. And HIV-related factors such as drugs being inherently resistant to the virus. HIV-2, for example, cannot be treated with efavirenz and other NNRTIs. And then you could have primary drug resistance. This is resistance that occurs even before a patient starts taking any drugs. It can also have transmitted, you can have acquired drug resistance, which occurs due to poor adherence. And then some viruses may have factors inherently that make them difficult to treat, including a high viral load. And then pharmacokinetic factors. Certain drugs require to be taken with food. So if those factors are not taken into account, you may achieve suboptimal levels of the drug in the blood. And then there are also factors such as drug-drug interactions. And a common example here would be treatment of TB in individuals who require either protease inhibitors or integrase strand transfer inhibitors. And then you could have several other factors that are related to the drugs. Next slide.
Next.
Okay. So this is what the Zambian guidelines say on the steps that need to be taken once somebody has a high viral load. As we mentioned earlier, the viral load is supposed to be repeated within 3 months. But in between that repeating of the viral load, patients should be enrolled in enhanced adherence counseling, including identification of several factors that we mentioned in the last slides. If possible, one should identify all the possible causes that led to a high viral load, and those should be addressed. And then once the viral load is repeated, and if it's still very high, they can be switched to second line, and then the follow-up continues. If the viral load is less than 1,000 copies per ml, then the patient is likely suppressed and you continue the treatment. Next slide. Now, how does one choose the next set of regimens? It's easy when somebody hasn't been on a lot of drugs before. Our first line NRTI backbone right now is tenofovir with either lamivudine or emtricitabine. So the second line treatment would include AZT or zidovudine with lamivudine as the NRTI backbone. If somebody was on AZT or D4T with lamivudine, the NRTI backbone in the second line regimen would be TDF and 3TC. Now, just additional comments on that. Our guidelines, the current guidelines just mentioned the first scenario, but in all the clinics where I work, we realize that there are patients who are on first line on AZT or D4T, and then they fail that regimen. So WHO gives this additional option. And our previous guidelines had given this option also for individuals who had been on a thymidine analog such as AZT or stavudine with lamivudine as a treatment. Then that NRTI backbone is usually combined with a protease inhibitor, which is boosted with ritonavir. And lopinavir and atazanavir have been the main drugs that we've used. Next slide. Next slide. Okay. Okay, so again, we'll focus on the green box, which refers to adults. The two middle, let me go with ABC and 3TC versus TDF and XTC are kind of similar. Then that first category that I'd mentioned where you have TDF and XTC with an NRTI. So that backbone will be replaced by AZT and 3TC with a PI, in this case, lopinavir and atazanavir. Currently, we're using DTG combined with TDF and XTC. And our guidelines mention that if somebody fails that regimen, the next treatment should be AZT with 3TC with a PI. Now, that regimen is what's recommended, but there's not much information, mainly because dolutegravir is a relatively new drug and there haven't been many treatment failures. So in short, there are no large-scale studies that have been done on individuals who have failed first line, which contains dolutegravir, and then with that NRTI backbone. So it is based on an assumption that somebody has never been exposed to an integrase inhibitor, such as raltegravir, and then has never been exposed to a PI as well. And I focused on the green box because the children, as you realize, would have been exposed to PIs, so they really don't neatly fit into what is easy to treat. I will discuss this a little more in the cases that we have, but just remember those two options of the NRTI backbone. Next slide. Okay, again, just to summarize, the management of first and second line treatment failure, the steps to take are that if a viral load is more than 1,000 copies per ml after 6 months on ART, the first step is to establish the cause of the high viral load. And this would include assessing patient factors that led the patient to stop the treatment, factors related to the HIV virus itself, such as pre-treatment drug resistance or other inherent factors in the virus, and factors related to the regimen. And in the regimen, it would include things like errors in the prescription or misunderstanding of the instructions. Instead of taking the drug twice a day, somebody takes it once a day. Once you've identified the cause, you go on to adherence counseling, enhanced adherence counseling, and then repeat the viral load within 3 months. If the viral load is high, you switch to second line. Now, if somebody is already on second line, the guidelines mention that you consult Advanced Treatment Center, or in this case, you can consult HIV mentors. So here's a scenario.
So this one is a bit different in that we'll have to discuss the case. So there'll be no discussion, sorry. We'll just have to go to the poll. So this is a 45-year-old male who has been on ART since 2009. The treatment history is as follows. On 29th May of 2009, he was commenced on ART, and the regimen was AZT, 3TC, and efavirenz. Then on 1st October, he was changed to stavudine based, which is T4T, 3TC, and efavirenz. In 2010, March, he was changed to ABC, 3TC, and efavirenz. And again, in 2012, July, he was changed to TDF, which is second line with boosted lopinavir. In 2016, he was changed to TDF, 3TC, and boosted atazanavir. The viral loads done in 2018, February, was 3,006 cells per mil. Then in August, the viral load went up to 9,517 cells per mil. And then January this year, the CD4 was done as well, which was 381 cells per mil, and the viral load was 4,370. So the poll question is, what are your next steps in the management of the patient, of this patient? A, order a genotype. B, change the regimen to TDF3TC and dolutegravir, which is TOD. C, consult HIV mentor. D, schedule the patient for 3 sessions of enhanced adherence counseling and then repeat the viral load in 3 months.
So the poll is coming out. Carefully read the question. We'll be able to see your responses very soon.
Oh.
So just go through the scenario again.
Okay, just to remind you, the regimens, the first one was AZT3TC with efavirenz. The second regimen within the same year, was D4T 3TC and efavirenz. And then the patient was changed to a triple, I think, and then later to a PI with TDF and 3TC.
Okay, so we seem to be having some technical hitches with the poll question. The internet is rather slow, but probably what we can do is discuss, the answers is there without people polling, although we'd have loved to see. Or maybe we can ask people in the hub to give us a poll. Anyone in the hub?
Any suggestions?
We'll divide into 3 groups.
Let me just read the regimens again. So the first regimen was AZT3TC with efavirenz. The regimen was TDF3TC with lopinavir, and then 2016 the lopinavir was replaced by atazanavir. So basically we've gone from thymidine analogs to ABC3TC and efavirenz, and then a PI with a TDF backbone.
So can we have some contributions? The group in front of me on my right. We can just scream what the choice is from A to D. Any choice? Yeah, whatever you have discussed.
And the people can talk.
What about the group on my right? From here? Any? Yes? A? So we have got A. Then on my left?
4,000.
Yeah. Okay, so we've got Dr. Islam calling for A. And yes, those who came through the chat, then there's D.
It is a long sentence.
Then there's a long sentence from Dr. Hudson, which is from the information available. We do not know when the patient failed, so we do not know the resistant pattern, if any. TOD would be good empiric choice, but the genotype would be helpful. D, so far we've got more people saying D, and then in the hub, we have got people saying A. Yeah. Yes, I think I must have heard something like an A was, yeah. So probably maybe Dr. Chamba, you can give us a brief discussion, then we can go back to the other poll questions which we didn't discuss.
So this is an actual patient scenario. The only things that changed are the age and the sex. It could have been male or female, but this is a patient, an actual patient, and that's all the information that was there. So there was no previous viral loads, but at the start, we have those 3 viral loads. This is one of those scenarios where probably most of these answers would be correct.
Congratulations.
The reason is what I haven't discussed in this session is the importance of resistance testing and how to interpret resistance testing in deciding the next regimens. And that information should be in the background of someone's mind as they're making decisions on what the next drugs are. And the suggestions that have been made by WHO and the Zambian guidelines are with understanding of the resistant patterns that develop in an individual once they failed treatment. So I'll just comment on the choices that are there. There are quite a number of studies. I'll probably just mention the NS trial and the Dawning study that looked at individuals who failed. These were done, had a number of patients from sub-Saharan Africa, looked at individuals who had who failed first line, and even without doing a genotype. So those who failed first line and followed WHO guidelines and were put on second line in the NS trial, they achieved viral suppression on lopinavir with any NRTI backbone, depending on the individual physician. And this was comparable to raltegravir with lopinavir. But in the more recent study, which compared dolutegravir with lopinavir as the additional drug, dolutegravir was superior. And that's the reason I put that option there. Of course, the resistance results would be very helpful in this patient. So a genotype would be very helpful. The only comment I would make on option D is that this patient has had 3 viral loads in the last 1 year and nothing has been done. The regimen has remained the same. So while enhanced adherence counseling should go on, that should not be the end. Something must be done about the regimen. So that's the only reason I put option D, is that in addition to that, something else must be done to change the treatment. One other option that somebody could put is a protease inhibitor with a high genetic barrier to resistance, such as darunavir, with an entity that's got a high genetic barrier to resistance. Again, none of these are backed by randomized controlled trials.
I like C.
C, yeah?
Oh, C is, goes without saying. That's kind of understood that it has to be.
And for the majority of our centers,
yes.
And I think here.
Yeah. Dr. Mui has a comment here.
This patient has been on ABC, tenofovir. So it's like if you are going to change, and you're just doing a single drug substitution.
That is true. That there's a question. I'll repeat the question. That if somebody is put on TDF, 3TC, and dolutegravir, isn't the person going to be on a functional monotherapy? So again, these are very kind of difficult scenarios. The mutation that you develop from abacavir generally, and Dr. Watson, I noticed is online, can comment on that, is generally you would probably get an L74V initially before you get the K65R, which affects tenofovir as well. And studies that have included dolutegravir have shown that even when individuals have partial activity to NRTI backbone, are still able to have reduction in a viral load when you add dolutegravir. So there might be some activity that you get from that regimen, even though it's not fully active.
So just to discuss, I think, for question number 1 before we go to the key messages. I think we didn't.
Okay, I can just comment on poll question number 1. So the difference there was that the question said after somebody has been on treatment for at least 1 year. So the guidelines say after somebody has been on treatment for at least 6 months. So you'd not wait until 1 year to assess for virologic failure. In other words, if somebody is failing at 6 months, That's enough according to guidelines to diagnose treatment failure.
So this answer was supposed to be false.
False, yes.
All right. Let's go to the second poll question.
One was 100%, so I got it right.
So this one, I think the consensus is that the question was, the choice was true, which was a consensus. Yeah, so we can go now to the key messages for today's didactic.
Okay, so when suspecting treatment failure, establishing the cause is very important. And then addressing the several causes, sometimes it's multiple causes, addressing those as you are making the treatment regimen change. And then management of treatment experienced patients can be very complex. When in doubt, it doesn't hurt to ask. And then switching of ART regimens should be accompanied by adherence counseling.
Yes, indeed. When in doubt, it doesn't hurt to consult. Dr. Chamba, probably as Chatonda is putting up the case, would you just emphasize the importance of the HIV mentors? And as you know, most of our facilities in the network are really at first level. And some of them are health posts, some of them are, clinics, which are even, less than district hospital in ranking. So can you just talk about a bit about the role of mentors, especially with complicated cases like the last, case study we had?
Okay, so I'll just go back, mention the first few slides that we discussed that talked about viral suppression in Zambia as a whole. So as you realize that not everyone is fully virally suppressed, and the treatments that we have in Zambia are powerful enough that it's possible to get well above 90% viral suppression. The reason we're not at viral suppression, the main one is because people are not identified as being on treatment, as having HIV infection, and therefore not on treatment. And then the second is some of the delays that are associated with switching people to effective ART regimen. And that could be due to several factors, including not being confident in what the next regimen is. And this is where the role of HIV mentors would really be very important. So I still ask a lot of questions to my colleagues that are in the room when I come across a patient that's complicated and I'm not sure what to do. So consulting, I cannot emphasize that enough. Consulting colleagues, those that are supervising us, and we have several HIV mentors that are dotted around the country that are a great resource, sort of closer to where everyone is working as opposed to the few advanced treatment centers that we have in the country. So I'd urge everyone to use that resource so that we ensure that everyone achieves viral suppression. As I mentioned before, the drugs that are available in Zambia right now are powerful enough to get most people fairly well suppressed, or at least have good virologic control.
Thank you very much. So we'll be going into the second part of our session today, and this is case number 12, which will be coming from Yeda District Hospital. So if we can put up, that's the last slide.
Hi, Chipasha, can you hear us? Unmute her. She's unmute her.
We can hear you.
Okay.
That's great.
Thank you very much. So if you can quickly go into the case presentation, and then we shall open it up for discussion later on. So over to you, Lucia Tembo and Dr. Chipasha.
Good afternoon, everyone. My name is Lucia Tembo, presenting from Yeta District Hospital, Sesheke. So we've got a case, female 26, HIV TB co-infected on CAT for 11 years currently. Smear negative, pulmonary TB, chest X-ray based since January 2018. initiated on ATT, but never took it. Defaulted cut and opted for herbal medications since from January 2018 to November 2018. Admitted 3 months ago for chronic GE and progressive weakness in the legs, leading to failure to walk. Hence, disseminated TB, that is pulmonary TB and spine, diagnosis was made. So, recommenced on 4FDCs and TDF 3TCEFV in that admission. So the medical and drug history from 2007 to November 2011, HIV diagnosed and CAT was initiated. And the drugs which were used were D40, 3TC, and NVP. And then from November 2011 to September 2018, switched to TDF, 3TC, NVP. There was immunological failure. January 2018, there was pulmonary TB, chest X-ray based. Gene expert was negative. Initiated on ATT, but the patient opted for traditional herbs, but was collecting drugs from the pharmacy and not taking them. October 2018 to January 2019, TLN switched to AZT3TC lopinavir because of the high viral loads. Then from November 2018, there was disseminated TB, which is pulmonary TB and spine. Gene expert still negative. So physical examination, the vitals. Okay. On vitals, the BP was 101/73, temperature 36.4, weight 37.7, BMI 16.1, length was 1.53 meters, respiration was 16 breaths per minute, and pulse was 69 beats per minute. Examination continued. The general condition was fair. There was no pallor, jaundice, no cyanosis. The patient was afebrile with slow mentation. Respiratory and CVS were normal. The abdomen, it was tense, no rebound tenderness, no masses palpable. In musculoskeletal, there were contractures in the lower limbs. Then there was an ulcer on the sacral region, approximately 1 by 1 centimeters with regular edges. Clean base with bone exposed. Surrounding skin was hyperpigmented. Central nervous system proprioception altered, unable to stand nor walk, but sensation was intact. So the labs, January 2011, we had CD4 of 371. June 2014, CD4 dropped to 65. October 2016, the CD4 was 70.
Lucia, I'm so sorry. I think you have another device on in the same room. So we can barely hear you, and now we've completely lost her. I don't know if it's internet. Let's check with the other folks. You can pick up the case, Dr. Mpeta.
Okay, so I think we'll pick it up from here.
Let's check if the network can hear us.
Can we get us from the hub?
The pictures. Okay, so yes, I think you can pick up the case.
All right, so I think there's some technical hiccups from Sesheke. So what we have showing on the slide are the labs which have been done. As we can see that there were some labs which were done from as early as 2011, the CD4 was 371, which dropped to 65 in 2014. And then in October 2016, it went up to 70, and the viral load at that time in 2016 was about 71,318 with an HB of 10.6. The CD4 was repeated in March 2017. It was low at 38. And then in the same March, the viral load now increased to 161,774 copies. November 2018, that is about 2-3 months ago, the CD4 was 36. And in January this year, the CD4 was 71. And the viral loads were pending. Other labs done in January was an HP of 12.9. The creatinine was 60.95. The AOT was 75.9. And random blood sugar was 4.7. Serum cut was negative. So this is the picture, showing the drugs that were being collected but not being taken. So this patient was actually making it to the health center, but they were not collecting. Back again.
The picture.
Okay, so you can see that both the first line and second line are in that bag, the TB drugs. Everything did not miss any pharmacy refill, but all of them were not opened. So the patient actually was just packing them in the bag. So the questions for discussions, I think, that are coming from Yeta District Hospital in Sesheke is, what should be the best ART regimen for this patient? That's the first question. The second question is, how best can we manage this patient? So through raising up of hands, we can ask people from the network to actually contribute.
Scroll to see if they are back on. Scroll. Dr. Mpeta, may you please summarize the case for us?
What age was it?
26.
Okay, so this is a 26-year-old female who started ART in 2007 and was initiated initially on D40, 3TC, and NVP. And then in 2011 was switched to TLN, which is tenofovir, lamivudine, and nevirapine due to immunological failure. And then in 2018, and she took this from 2011 to 2018, and in 2018, in January, she was diagnosed with pulmonary tuberculosis based on chest X-ray. She was initiated on ATT, but as we have been told that she did not take any of the drugs, including the drug that she was switched to in terms of the ART, but started going to traditional healers, and she was taking traditional herbs, though she continued coming for pharmacy refills. On ART and ATT, and then a few weeks later, the following month in November, she presented with some diarrhea, of which they thought the ART, the boosted lopinavir, was causing the diarrhea. And at that point, she was switched to TLE, and ATT was continued. So this change from second line back to first line was because of the intolerance of the boosted lopinavir, and that's why they went back. Now, the question they have is, what is the best regimen for this patient? So we'll open up discussions from the network. If you could raise up your hand. I mean your retry, not the retry the hand, but from the Zoom facility. I don't know if it's also called an emoticon. And I don't know if we can see everyone. We can? Is there a hand? So any thoughts on this case? Maybe probably we could try to impose. Chadiza, are you with us? So since the case is coming from the far west, we'll pick on the far east, which is Chadiza.
Dr. Matua. Dr. Matua.
Good afternoon, Chadiza.
My comment is that, first of all, the big issue for that patient is not adherent to the treatment. She's not taking the drugs that she's supposed to take. I think that is the first thing that we should tackle, to counsel the patient, to allow the patient to be able to accept to take the drugs. Then, after that, since she hasn't taken any of the drugs, I will say the first line is still standing. We can still put it on the first line treatment as long as she hasn't taken any of the drug that was prescribed before. That is my comment.
So thank you very much, Doc, for that contribution. Although we note that the patient was recommenced on ART in November. So since November to date, she has been consistently taking the drugs. Senanga, any of your thoughts to what your neighbors have raised there? Senanga?
Answering under adherence.
Answering under adherence was that patient, when he was keeping medicine, there was no...
Senanga, sorry, you are a bit far from the microphone. If you could move closer.
Okay. I'm saying that is counseling under adherence. What I mean is, someone is sick that he needs someone to prepare for her or him. But there was nobody there. That's why she was doing like that. That's why adherence was not there. So that person was supposed to be given mandated time getting his medication. But that thing was not there. That's why it was like that.
Okay, I think what we have gathered is that Senanga is talking about adherence counseling in this patient, although the line wasn't very clear. Livingston, what are your thoughts from the south? Petauke, since your hand is up.
Thank you. We feel that this patient, of course, need adherence, but it looks like the case is very special. We are suggesting if the patient can be put under DOT, so that can providers can monitor how the patient is taking drugs. Then within 6 months, if she's not working, she can have benefit from DOT. And within 6 months, we can recheck the viral load. But we still keep her on a favirenz. I think that is appropriate for her because we are not sure for what she was taking before she took or she didn't take. We consider that she has now started taking drugs. We keep her on a favirenz, and then we do viral after 6 months.
Okay, so that was Betauke giving us their thoughts that we keep the patient on TOE, and then in 6 months, which is 4 months from now, we repeat the viral load. Any thoughts from the app?
So, I'm not sure. Are they able to
Pasha.
Chipasha and Lucia? Good afternoon. It's obvious from everyone that there's an issue of adherence here, and we need some psychosocial counseling. However, I didn't hear it come out in the history in terms of the socioeconomic environment of this patient? Are there social issues such as alcohol? Has this patient disclosed their status to close family members? I think we have to address those issues. Probably those are the barriers to access to care. Also, religious beliefs here and the cultural beliefs here, I think, playing a very big role. So, my opinion would be, would need to not only involve the psychosocial counselors, but you probably have to get the social workers involved in this case. As to the regimen, really it's very difficult. Did this patient actually take any drugs previously, or did the patient get on ART on and off? Whereas we can settle for an empirical regimen at this stage, I think in this patient, we'll still have to do a genotype at one stage, maybe in 3 months' time. Given that we're talking about Sesheke, we'll either have to send the sample to Lusaka or to Livingston. I'm not sure if they are able to do genotype in Livingston. But I think that's the line of thought. So we have to approach this very difficult situation from various angles, and let us understand the home environment of this patient. Otherwise, like someone observed, that the patient might need dots, but how can we put dots, ART on dots for life? So we have to handle the barriers. We tackle the barriers during this time when we have the patient in the hospital.
Thank you very much, Dr. Chanda. Any thoughts from people in the hub? There is a hand. Which hospital is that?
Hi, Chikasha, I see you're back on. Can you hear us now?
Yes, we can.
Okay. Sorry, I don't know how much of the discussions you have gotten or missed, but I think we finished off the case, and a number of people have been raising their concerns, and notably Chadiza has given their thoughts in that this patient will need adherence. And I think people want to know that after recommencing ART, has adequate counseling for adherence been done on this patient? Is she off again?
I think they're off.
Okay, I think they seem to be having, no, they're there.
Pasha, can you hear us? Yes.
Okay, so probably we are still having issues. Any other comment before I call in Dr. Chambwa on this point and those behind? Are we seeing these patients from the hub? Are we seeing similar patients? Okay, so what are we doing about it? Dr. Mwituma, any thoughts about such kind of patients? Those who have free just help.
Sorry. Okay. I think from what Dr. Duncan Chanda has mentioned, besides strict adherence counseling, patients like the one that has just been presented, I would recommend a genotype. Since we don't know when this patient did take ART, did they take ART initially before a few years back in 2007, or did this patient also just recently start this year or last year? So I would recommend a genotype and wait for the result before we could choose the best regimen for this patient.
Okay. Thank you very much, Dr. Mutuma. Dr. Chamba, maybe before we talk about the regimen, any thoughts and what sort of counseling do we give to patients? Because we have got a number of patients who would come and tell you, I've gone herbal. And I think these are, part of the most difficult patients. How do you approach such a patient when they say, I've gone herbal? What, as an HIV physician, what would you tell that patient?
Patients who choose alternate treatment are often sort of challenging. It's hard to convince them. So in this patient, we know that adherence is a factor in the treatment failure. But maybe, I know we discussed this as we talk about the regimen change. So I mentioned in my discussion that the 3 groups of factors that contribute to high viral load include patient factors, factors related to the HIV virus itself, and then factors related to the regimen. And in this patient, all 3 of those factors do apply. The regimen is probably suboptimal, and there are several things we can say about it. But we have a history of use of herbal medication, so there was clearly non-adherence. One of the things that I try to do is find out why they're using herbal medication. They may falsely believe that herbal medications work better than the drugs we have. So I'd start by correcting that notion, but sometimes it doesn't work. It requires multiple interactions to change that kind of thinking. But I think, as everyone has been saying, discussing with the patient, finding out the reasons why they're choosing that regimen instead of what's known to work, giving examples of people who've done well, and until they change their mind. But there are times where it's really difficult to change that kind of thinking.
Now, coming back to the question from Yeta, which is what regimen should this patient be on? And the reason why they're asking is, at the moment, this patient has been put on first line, which is TRN. Now, if we see the treatment history, this patient started treatment in 2007. They have been exposed to thymidine analogs, and the change in treatment was due to treatment failure. And if we see how the treat was done then, we still have quite a number of comments. Now, looking at the current regimen, which is TOE, a first line, and after having such kind of experience, what really should be the regimen for this patient? And this is what is the number one question, or the biggest question from Yeta. Should they continue with the TOE? Should they think of something else, looking at the history of this patient?
Okay, so this patient is complex. I'm not sure that I have the right answer, but the additional complications that the patient is on treatment for TB, and if we had rifabutin, would recommend that rifampicin be replaced with rifabutin so that we have more treatment options available. So the principles of changing treatment are that there should be a minimum of 2 active agents, and if possible, 3 active agents. So looking at the treatment history of this patient, 1 active agent would be something they've never been exposed to, such as an integrase inhibitor. And a drug like dolutegravir can be given when someone is on TB treatment if it's taken twice a day, 50 milligrams twice a day. So that would be one option, to have an integrase inhibitor that's included in the regimen. And then you look at the treatment history in detail and see if you can come up with another drug that is fully active, or at least partially active when you combine them. And again, we can't really use a drug like darunavir because of the interaction with TB drugs. So you'd be left with a suboptimal option of at least using a PI such as lopinavir at a higher dose, so that you can give it together with the TB drugs. And I agree with Dr. Muituma that a genotype would be very helpful, and genotype results. An integrase inhibitor such as dolutegravir twice a day, and lopinavir, which is twice the usual dose, and then review the other drugs and see which one would work best, and then modify the treatment based on the genotype results.
Okay, thank you very much. We've got Douglas Watson, who is contributing from the US, saying that the caveat here is, if the patient has been grossly inadherent, is that the genotype will come out without any resistance because of returning to the wild type. So he suggests that we need to continue monitoring the viral load closely as we start a new regimen. Now, the second question is, so, yes, Dr.
What should these people do now?
Yes.
What should they give now?
So I think from what Dr. Chambo has explained is that there will need to be on dolutegravir, which is, doubling the dose since we don't have rifabutin, and a PI, boosted lopinavir, which should also be double dosed. But if there was rifabutin, if I got him correctly, is that we can use this in normal doses and hence lessen the.
We could use the darunavir for rifabutin.
Yeah.
Because you are expected, you are likely to achieve viral suppression if you had, say, a combination of darunavir with dolutegravir, both of which have high genetic barrier to resistance.
So do they have dolutegravir?
Dolutegravir?
Do they have at this facility?
Dolutegravir, we are now going, yes, Dr. Follow.
So all advanced treatment centers should have dolutegravir, but they have the option of using it in the TLD form as well, as they combine with other drugs. However, they can order them from MSL. MSL has dolutegravir.
What it is, they are TLD, fine.
They lose dolutegravir.
So you still in the morning, standalone.
They would have to.
In 2 weeks.
Yeah.
So
we don't know.
No.
So let's look at the ART history. Chatonda, if you could bring back on the ART history.
Apologies, everyone. We have a huge problem with internet in Lusaka since last night, it looks like. So that's why we are going on and off. Essentially, the patient is on TLE since January. We're trying to make some sort of regime for this patient. Dr. Zico.
Chatonda, is it possible to bring up the slide?
Okay.
All right.
I seem to want to concur with Dr. Muya. This is a difficult patient that we have. We don't know if this patient has been taking the drugs, and the patient has currently been on TLE. How about we leave the patient on TLE, which is a simple regimen, but we don't know if it will work, and then accelerate the genotype result, which will now give us a more reasonable regimen for the patient. That's my thinking.
Okay, yes, Dr. Chanda, you can go ahead.
I think the problem with that is like Prof. Watson just said. If, let's say, and also Dr. Chamba alluded to, don't achieve N viral suppression. If you come and do the genotype, it might come out sensitive because this patient is going to have a lot of wild type viruses outcrowding the resistant viruses. It's a very difficult situation. So I think if we said we maintain TLE, Dr. Chamba, would it be helpful to monitor the viral load much closer then and see which direction we are going to?
Again, the guidelines usually tell us to check viral loads every 3 months and stuff. Now, if I was treating this patient, I would check the viral load every month.
Okay.
Obviously at a huge cost, and I would not recommend that for everyone in order to kind of really know what's going on. But to make such a recommendation to the wider community, I would not, because everyone will be quoting Dr. Chamba saying, check viral load every month. So don't do that. Yeah, so.
I mean, it's a very ill patient.
But it's different.
So I think that does sound reasonable to check frequently. And so actually for me, the question in my head is, okay, this person is already on TLE and probably just not doing well clinically, right? From everything that we could say. Before we change, should we get a little bit more information so that we can properly monitor? Now, the question in my mind is whether that information is genotype or just another viral load to know, and I think it's both in this case, recognizing that the genotype may not be so helpful, but at least we'll know which direction we were heading. And likely, I'm sure the viral load is getting higher, at which point then you would switch. But the problem is, I think this person's life is hanging, so we might want to switch before that.
Let's closely look at this patient who from 2007 was on stavudine. And then let's look at the switch which was done in November 2011. The patient had failed stavudine and then was switched to TDF, 3TC, and NVP. Was that an appropriate switch?
Sorry, Peter, but it depends if it was a programmatic switch.
There's immunological. There's a reason.
But you see what this is because this patient is not adherent. We know that you are taking the drug.
Yes.
So this is deterioration because of failure to take drugs.
So at this point, the patient had some drug pressure, and that's why they found the failure.
Presumed drug pressure. This is a patient where you've brought out a picture and she's never taken any drug.
Yeah.
For all we know, she's probably never taken anything.
Okay.
And that's why, for me, I strongly feel we keep her on something she can take, which is TLE, one tablet, not complicated. We understand what exactly is going on. We follow up that viral load closely. I think somebody brought up something very important. He is very sick. He has spinal TB. He's bedridden.
Yes.
And I understand why I would want to be very aggressive. But he clearly doesn't take any of these drugs. So we are really between a rock and a hard place. But I think more than anything, this patient needs time. We need to spend time counseling the patient. And that's what I learned in my training. And we may have to force ourselves to do very frequent viral load because whichever way, it will be very complicated for this patient.
Okay. So starting from November, after the hospitalization, this patient has been linked to a counselor, community counselor, who is administering DOTS.
Okay.
So if we are to assume that now compliance is there for now because there's somebody who is actually administering the drugs from home, because this patient now cannot walk. So there's somebody who is going there. And this is as we discussed with the people who presented the case.
Okay.
What should be the regimen? And I think that's the biggest question. So are we going to go aggressive or are we going to go with the TLE, which is there? And I think, I don't know if they are still back. Sesheke.
It's a message from Dr. Suppression.
Dr. Suppression, can you hear us?
Okay, yes, they are saying we can hear you for now, which is using a mobile. All right, so, and bit of verification, no history of alcohol. Okay. Social system has been very weak. However, the family and patient had 2 counseling sessions. So this is just them contributing to the, we don't know which mobile they are joining in. Maybe if they could clarify a few things here and there. Mr. Chatonda, are we able to locate them? Okay, yes, brilliant. So if you could say a few comments on what has been discussed so far in terms of adherence.
Okay. The only thing we got before the break in the connection is the question with regards to any history of alcohol intake, smoking, and also the social background. So those are the things that I was clarifying to say our patient has never taken alcohol. But what was of note is that the social support has essentially been very weak with our patient, and we so far cancelled both the patient and the caregivers. So 2 studies have been conducted so far. We plan to continue with that. Thank you.
Okay, I don't know if there's any other clarifications. And I think the other major concern is that this is a patient who has actually not been taking their drugs from inception.
Also, when I think about, I'm just thinking that this person was a child essentially when they were infected, right? They were 15 years old. So maybe what were the circumstances around that?
Okay. Pasha, are you able to get that second question?
Sorry, can she repeat the question? Sorry, we couldn't get her clearly.
I was just reflecting on the fact that this person was a child. They were essentially 15 when they were infected. So maybe what were the circumstances around that could be influencing their decision to not take medicine? Like, what's the root cause of this person's issues?
What we know is the mother passed away about 3 years ago. And she strongly believed that herbal medications would treat her illness. So this is a patient who strongly had this firm belief that herbal medications was the way to go. And so we've been trying to get her to realize that the treatment that we're administering right now is for her benefit.
What did the mother die from?
We are not sure.
They're not sure.
They're not sure.
No.
Mary, has it been adequate answered? No.
Yeah, but it's fine.
It's okay.
I think we just don't know.
Yeah. Okay. Any other things maybe you would want to say? We know that you went offline before the recommendations come through of what ART this patient should be on and what other things we should do going forward. Dr. Suppression?
Okay. Yes, I think our concern was we weren't really convinced that the high viral load was due to drug resistance because no one is really sure about how our patient has been taking her medication. And so we felt we need to put her on TLE for purposes of the pill burdens. The patient we commenced on ATT. We didn't want to burden her with the pills. And then we'd also like to find out if, sorry, we did not get the comment on whether this is appropriate for now, what to put the patient on. And would like to know if after the enhanced adherence counseling sessions, when we get the repeat viral load, what should we do for our patient? What can we put her on?
Dr. Chambo, any thoughts?
Okay, so on the last question, so I think the patient has been on TLE for a month now, so you can repeat. If it's been a month, you could do a viral load now. And if there's no significant change between the last viral load and the current viral load, and this again, you can check with HIV mentors, there's a definition of what a significant change between two viral loads is defined. So if the viral load is either the same or going up, then the patient is unlikely to suppress, especially that they've been monitored more closely. In that case, we need to put them on an effective ART regimen. And so if we're able to get, so what I would recommend now is that you do a viral load now if it's been at least a month, and then just consult once you get the viral load, whether the two viral loads are statistically significantly different. And if they are, and it's coming down, then one is on the right track. You can continue monitoring the viral load. But if it's not, then a regimen that I suggested earlier would be looking at the treatment history. This patient has been exposed to thymidine analogs. If during these last 11 years, they've developed drug resistance, which most likely they have, the mutations that are likely to be there include thymidine analog mutations because they've been on D4T and AZT twice. And if during those times they were taking D4T and AZT, adherence was suboptimal, they probably developed thymidine analog mutations, which generally affect the entire class of NRTIs. So the current regimen is unlikely to be fully active. And then we know that efavirenz and nevirapine are usually the first ones to be affected in addition to lamivudine. So an effective regimen would include an integrase inhibitor such as dolutegravir with a PI like darunavir. And if darunavir is used, then you would need to use rifabutin instead of rifampicin for the TB drugs. So I guess this would buy a bit of time while waiting for the viral load. You could start making arrangements for rifabutin from MSL or Lusaka. That's my recommendation.
Hi, Pasha. Can you still hear us? Okay. Yes. I'll just summarize. Oh, perfect. I'll just summarize our recommendation. First of all, we want to commend you for really bringing this patient to our attention. The bad news is that these things happen. They happen everywhere. It's a complex case. I think we need to acknowledge that. The good news is that if you have something like this, we have Dr. Achamba for that. So we are going to do this with your patient. We'll keep the patient on TLE. Since it's been more than a month, we request that you do a viral load. If the viral load is more than 1,000, please send over a genotype. Remember to separate the samples. Last time I requested a sample, it came as full, the whole blood, okay? You separate the sample and forward that sample to us. If she's still, if it's unsatisfactory, the suppression, we do the viral load today. We recommend that you put her on darunavir and dolutegravir. The dolutegravir will be once a day because we are going to send you some rifabutin. UTH ordered rifabutin for patients like this because we see these patients all the time and we'll send it over to you. So we'll send you some darunavir and DTG so that we put her on something that will definitely work while we wait for the genotype. Then with that genotype, we'll be able to advise. We acknowledge that you may have some archiving, and then we'll help you come up with a better regime. So let's put her on the PI we know will work, darunavir, and we know dolutegravir will work. And then when we get a genotype, we'll advise further. No, PTT.
Yeah, you could add another drug, PTT. But take into account the issue of pure burden and everything. Again, yeah, this is a complex case. The only way you'd know it works is if the viral load gets suppressed.
So Dr. Chipasha and Lucia, thank you very much for that case. And from today's discussion, we know that a lot of issues have come out from these patients, that is, those which are bordering on the patient factors, and including, difficult to counsel patients. I think it's something that we encounter in our daily practice. Patients' beliefs also and how they impact, adherence to treatment. It's something that has been brought out. Drug factors as well, drug interactions, drug toxicities are also of a real nature, and the issues of people burden as well on these patients, and the social support system and how it is important in ensuring that the patient receives optimal care. The other important aspect, I think we've been reminded on the need to consult, and we know that some of the lapses in the management of this patient was because people felt isolated. So please don't feel isolated. And if you cannot get hold of your HIV mentor, you are still reminded that the line 7040 is still functional, and you can directly call the center so that you can get real-time advice on some of the patients you encounter like this. And I think it has been a fruitful discussion, and we thank everyone for coming. And I know that we had people from the Far East, which is Chadiza, and having contributed, especially that the case was coming from the Far West, where the sun rises from. I don't know if the sun rises from the east, but some I know that it rises, and they are the last one to receive the sunlight. So it was quite interesting, and a number of people in the hub, which has been filled to capacity even today. Next week, the session, the topic will be antiretroviral toxicities, and the presenter is going to be Dr. Paul Zulu, who is an infectious disease physician, and they will be joined by discussants like Dr. Floyd Mlinga and others. No, Dr. Fellowship, any other announcements?
No, but thank you very much, Dr. Achamba, for coming to the hub. And Dr. Chipasha, sometimes you write a lot of drugs and the patient is actually not taking them. So that picture was very, very helpful. Thank you, Chipasha.
Thank you very much. And from every one of us from the hub, have a pleasant evening and see you next week.
A wrap.